Technology can accelerate what we know about movement and the impact on risk and performance. Stay tuned because today you will learn the current research related to ACL injuries and assessment for return to play. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute, and your host on the Sports Rehabilitation Virtual Summit. The purpose of the Sports Rehabilitation Virtual Summit is to provide healthcare professionals with clinical solutions to help athletes recover from sports related injuries and improve athletic performance. I'm honored to welcome our next guest expert. Dr. Nessler is a sports medicine physical therapist with 25 years' experience. He's a published researcher, author, and innovator in sports medicine, ACL injury prevention, and movement assessment. He's the co-founder of the ViMove AMI, a 3D movement analysis that has been used to assess 80,000 plus athletes across 5 countries. Dr. Nessler is also a black belt in Brazilian Jiu-Jitsu and combat athlete specialist. Today, he'll be sharing with us the use of technology for objectively assessing movement for risk and a return to sport post-injury. Dr. Nessler, thank you so much for joining us as a presenter on the Sports Rehabilitation Virtual Summit. Please take it away.
Well, thank you very much for having me, and very excited to share with your audience what we are doing as far as technology and movement assessment. As you said, my name is Trent Nessler. I'm a sports physical therapist and really have been on this journey to really do something impactful to prevent ACL injuries. I just put a few studies on here that really drive my why behind what I do. And that really is to prevent injuries in youth athletics and also help to improve overall performance. As we know from the research, there's over 200,000 ACL injuries every single year. And this is despite all of the facts that since 1997, there has typically been over 1,000 papers published on an annual basis related to the biomechanics that go behind some of these risk factors. And yet here we are today, and we are still having this rash of ACL injuries, which equate to about a $5 billion healthcare cost on an annual basis. And 79% of those who have an injury 12 years later develop osteoarthritis. And the re-injury rate is really high. Over 28% of athletes who suffer an ACL injury will end up having another ACL injury at some point in their athletic career. So if you look at these statistics, what you see is that there's really a lot of opportunity to really improve what we do. And that's really what's driven my entire career. There's a lot of different products that I have tried to put out into the domain to really address this issue on a large scale. The one I'm going to be talking to you about today is the ViMove AMI, or Athletic Movement Index. But more importantly, why do I do this? So one of the things that was super important to me is that as we developed technology was really to create a database by which we're able to capture large amounts of information. Because what we know is that traditional biomechanical analysis takes a lot of time. In order for a biomechanics lab to collect a lot of information, it takes about 4 hours per subject. And in order to do that on a large scale, you're talking 10, 15, 20 years. This is actually a paper that was written by Timothy Hewitt. Timothy Hewitt, in the world of ACL, he is the most prolific researcher as it comes to biomechanics related to ACLs. And he did this clinical commentary a few years ago related to how technology is advancing what we know about human movement. Because of the technologies that we have today and the way that we're capturing data on a very large scale, what we're seeing is that we are learning things at a much faster pace than what we've traditionally learned through research. So, and I know when we originally started this, it was around 80,000 subjects, but we've actually increased that to over 90,000 subjects. And what that means with our technology, 90,000 subjects across 5 different countries, we collect 3,500 data points for every assessment we do, which equates to over 315 million data points related to human movement. So what I'm going to share with you today is not published research, but it is data that we are capturing on a large scale where we're able to start to see some normative values, and we're starting to see where certain trends are starting to come as it relates to human movement, risk factors, and most importantly, clinically, what we can actually do to improve those movement factors. So number one, what we know from the research is that dynamic valgus, whether you're a professional player or a recreational player, dynamic valgus is the number one thing that we need to measure as it relates to risk for a lower extremity injury. Dynamic valgus is pictured right there in that young athlete. And what we know is that this dynamic valgus position leads to the majority of ACL injuries that we see. Majority of ACL injuries, over 70, 75%, depending on the research you read, are related to non-contact. That means that nobody hits you. It's simply a change of direction or something along those lines. And typically what happens is that the limb is in this dynamic valgus position. So we need to be able to measure that. We need to be able to measure that to see what are the components that are adding to that. And most importantly, what do we do from a treatment perspective to address that? Now, on the previous slide, I had papers from 2018. This is 2023. Another published paper that says, again, dynamic valgus is a major issue that we need to assess. But here's the thing that we're starting to find now. Because we are actually measuring pelvic movement, what we're also seeing is that this lack of pelvic stability also has a significant impact, not only on loss of balance, but it also has a significant impact on that dynamic valgus. So for example, when you land on one leg and your hip moves into a retrotrendelenberg position, which is the position this pelvis is in, your center of mass moves over that limb. And when you land, what that does, it creates a force vector that drives your limb into a much greater dynamic valgus. And what that means is that there's a much greater force that is imparted to the MCL, to the meniscus, as well as the ACL. And what we know is that if we can reduce that, not only do we reduce that force vector, but we also reduce that overall risk. And one of the number one ways to measure dynamic valgus is single limb performance. So when I say that, when I say single limb performance, what I mean, single leg squat, a single leg hop, a multi-directional hop, we know that these movements tend to really bring that out. Now, even though single limb testing is super important, we also know that bilateral testing is important. So things like a squat. So why do we look at a squat? We look at a squat because we know that there are certain things that if you present with, put you at greater risk. For example, if you're shifting your weight off to one side, what we call lateral shift, if you shift that weight off to one side, your weight distribution is unequal on each side. That means one hip's getting more force, one hip's getting less force. And most importantly, what it means is that strength deficits occur. One side's always going to be stronger, one side's always going to be weaker. And what we know is that if we can improve that efficiency of your squat, we're going to improve your overall sprint speed, your vertical jump, and we're going to decrease your risk for injury. We also know now that there is a strong correlation of concussion to ACL risk. Yes, I said it, concussion and ACL risk. If you look down at that last paper there from McPherson in 2020, you are at a 1.6 times greater risk for an ACL injury up to 3 years post-concussion. That has all the researchers going, why is this? Well, let me tell you, we actually measure concussion and we actually measure limb movement. And what we've seen is some strong correlations to concussion and some of the things that it's doing from a single limb performance perspective. That being said, most importantly, what it's also doing is guiding us on what we can do clinically. So this is what our test looks like. You do a plank test, a full squat test, and then what you're going to see is that the remainder of this test is single limb and performance. We do a right side plank, left side plank, and then we do everything on the right side, and then we do everything on the left side. Part of that is to bring in some level of fatigue, and most importantly, to be able to measure that single limb performance. So we also have combined that with a wearable sensor technology developed by Dorsavi, which is out of Australia. And what this allows us to do is actually capture lab quality data during the performance of all of these movements. So this technology is allowing us to capture movement within 2% of a Viacon system, which has never been done before. So we can do that effectively and efficiently in mass physicals so that we can assess a large numbers of individuals. What these sensors do, there's 4 of them. You can see them there, and they capture this movement at over 200 frames per second. that's faster than the human eye. And most importantly, all of this information is then interpreted via a computer. So it's no longer subjective information. This is all extremely objective information and provides us a lot of information. And then most importantly is we're capturing all of this data from all over the world. So every single user is going into one mass database. What that does is we can take that blinded information, we can tweak out certain aspects of that data and find out where those trends occur. And most importantly, we can use that to drive better clinical interventions. So let me say a couple of things. Number one, poor biomechanics. So why do we look at biomechanics? Because we know that if you have poor biomechanics, force attenuation is going to be changed. That's going to increase your risk for an injury. But just as importantly, poor biomechanics means there's altered force production, and that means decreased athletic performance. So in theory, if you improve biomechanics, you should decrease risk and you should have an impact on athletic performance. That's no longer a theory. We've actually seen it. We've seen improvements in vertical jump. We've seen improvements in sprint speed, and we've seen a reduction in all lower kinetic chain injuries. That means foot, ankle, knee, hip, and low back. So what does movement tell us? There's a lot of different things that movement tells us. Number one is, what is the root cause? What is the weak link in the system that's adding to the problem? So I'm going to give you one example right here. We have a step up. We're looking at dynamic valgus. If that's the movement we're looking at, what is the driver of that dynamic valgus? And what we have is two very distinctively different root causes for that dynamic valgus. In the first scenario, you see, as soon as she starts to load her foot, her arch completely collapses, which would then drive her knee into that dynamic valgus position. In the second scenario, what you see is her foot and ankle is in a neutral position, and she is driving into that dynamic valgus position. That is more of a hip weakness. Same movement, two totally different scenarios. One, I'm going to do foot and ankle strengthening. One, I'm going to be doing more hip strengthening. So what about a side plank? I love this because I've never read a research study on this, but the side plank can tell you so much about human movement. Number one is that if we look down at the foot and the ankle, what we see there is what we call a tibial drop. Tibial drop is unusual. Normally, people's ankles stay in a neutral position when they get into a side plank. If they have this tibial drop, it tells us a lot about your anterior tib and your peroneals. We know that there's some weakness there. And guess what? People who demonstrate that in a side plank, if they play basketball, they're 3 times more likely to suffer an ankle sprain. Then we go up to the hip. We know that the most highest EMG activity in a glute in your side plank is the glute medius. And what we know is that if your hips drop down or they elevate up, is that that is an indication for glute medius weakness. Looking at your hips, if your hips roll forward or they roll backwards, it's going to tell us a lot about quadratus lumborum and your transverse abdominis. And then up at the shoulder, if your top shoulder rolls forward, what it tells us is that your bottom shoulder, the serratus anterior and the rhomboids, is not strong enough to hold that scapula against the rib cage, and it's allowing your body to roll forward. So a tremendous amount of information that you can tell simply from a side plank, and most importantly, how we actually are going to address that. So what are some of the biggest lessons that we've learned from all of this mass data? There's a ton. So what I'm going to give you is a few of those key points. Number one, dynamic valgus speed matters. We've always known that dynamic valgus is an issue. Magnitude of dynamic valgus is an issue. But we all know that if you were to stand up right now and put your knee at 20 degrees of valgus, probably wouldn't hurt you. But if you did that at 450 degrees per second, you're probably going to rupture something. So speed is super important. Secondly, we are the first ones to actually measure pelvic motion. And what we're seeing is that not only is pelvic motion important, your ability to stabilize your pelvis, but also the speed at which your pelvis falls has a direct correlation to risk. We've also seen that if your pelvis falls into a Trendelenburg, you're more likely to lose your balance. If your pelvis falls into a retro Trendelenburg when you land, that's actually going to drive your knee more into a dynamic valgus. So again, The position of the pelvis at landing has a big indication of what it's going to do to your overall body. Third is power variance. We know that there is a correlation of a drop off in power over time that equates to risk. If your right side drops by only 10% and your left side drops by 40%, that's a huge problem, especially in athletic types of activities. Fourth is kinesiophobia, fear of movement. Fear of movement has a direct driver on human movement. We use a form called the TSK-11, Tampa Scale for Kinesiophobia 11 form. It's a very well published patient-reported outcome that we've seen has a direct correlation to what we see from a movement perspective. And then finally is concussion. Concussion has a big impact on dynamic valgus and loss of balance. This is what our test looks like. This is what the data looks like. Gives us a lot of information. Couple of things that I'll say. Number one is that we know that when you're doing return to sport testing, one of the things that's really important is LSI, limb symmetry index, comparison of that right side to that left side. What we also use is what is called limb quality index. This is a measure that we do that is the quality of the movement during the performance of the task. So you can have LSI, you can be equally bad on both sides and have an LSI that's 100% because you're equally bad. But LQI is more of a quality measure. What is the quality of that movement during the performance of that task? So we give that both a number, we give it a visual representation on the report so you can actually see what is the limb doing, and then we actually put some quantitative numbers to what those factors actually are. And most importantly, we want to decrease not only averages, but also max numbers because we know that those max numbers are typically the ones that cause the injury. The averages are the ones that usually cause those repetitive injuries. So some of the clinical take-homes, a lot of great clinical take-homes. Number one is the importance of nutrition. So one thing I've been talking a lot about, one of the things that I see from a health standpoint, number one is gut health is super important to your inflammatory response after surgery. If you've got poor gut health, you are going to swell more after surgery. And most importantly is preoperative and postoperative nutrition can make a 4 to 6 week difference in your rehab times. That big of a difference. There's great published research out there related to that. Secondly is BFR, blood flow restriction training. Early implementation of blood flow restriction training is a game changer. It is probably one of the biggest things to hit the rehab industry in probably the last 15 years. You get two things from that. Number one is you get more motor unit recruitment. And the second thing is you get a systemic effect of a release of growth hormone and IGF-1 that is significant enough that it actually adds to a significant improvement in your outcomes in a shorter period of time. Other big clinical take-homes, control dynamic valgus. Magnitude and speed are very important. The higher the speed, typically the more links in the chain that are involved. Your higher speeds, that means your foot and ankles involved, the knees involved, the hips involved, the core's involved, and you got to look at all of those links in the system. Loss of balance, really critical for risk assessment, but also one of the things that we see is that people will say, I have good balance on this side, horrible balance on that side. It's not typically a balance issue. It's a stability issue. Finding the root cause of that stability that's adding to that loss of balance can make a big impact. Kinesiophobia has a direct tie to lateral shift. In a squat, when you correct lateral shift, you see kinesiophobia actually goes down, and also quad deficit. If there is a quad deficit on one side versus the other, you typically tend to have higher levels of kinesiophobia. And then finally, concussion. Concussion does have a direct impact on both valgus and speed of valgus. It also has an impact on loss of balance. That loss of balance you actually see on both sides. It's a stability issue and it's a balance issue. So degradation over time, we know that that's an important factor. We are measuring that. We're also measuring the impact of fatigue. These are things that we're not reporting yet, but we will report eventually because we know that there's a super big importance of both of those factors as it relates to risk. And then finally is that pelvic stability during single limb performance. Controlling both pelvic stability and dynamic stability is super important for reduction of risk and driving athletic performance. So what's next from all this? Really thinking super big. How do we get this to a larger scale? Number one, first and foremost, doing presentations like this. Thank you so much for having me because I love this. I love sharing what we're learning. And most importantly, helping clinicians understand human movement better so that we can truly impact ACL injuries. We should not be having 250,000 ACLs every single year. If we're all doing the things right, we should be able to drive these numbers down. We also just launched an international study with 3 different countries with Timothy Hewitt, where we are looking at what movements that we measure are the most predictive for injury risk. And most importantly, my goal is to have over 1 million athletes assessed by 2028 so that we can make stronger correlations, so we can make better clinical improvement. And then most importantly, driving that beyond just sports. We actually are looking at military applications, fitness applications, beyond just what we do in sports. And that is my presentation.
Dr. Trent, thank you so much for sharing with us your brilliant presentation today. I have so many notes. I want to do a summary and then a couple questions for you for
Absolutely.
implementation. We learned so much from you. All right, you talked about your why at the beginning, where over 200,000 ACL injuries occur per year in the United States, $5 billion industry, 79% will go on and get osteoarthritis, about 29% will have another injury. You created a database to capture information about biomechanics, and you've captured more than 3 million data points on subjects. And you talked about research studies from Hewitt in 2021, who's a prolific researcher who wrote about technology to capture data for movement assessment. And then we talked about non-contact mechanism of ACL injury. So dynamic valgus is the number one thing to measure. It leads to a majority of ACL injuries. 72.5% of injuries are non-contact, and lack of pelvic stability has a significant impact on dynamic valgus. So for example, with the retro-Trendelenburg position, if you land in that position, it drives leg into a greater valgus position. Need to reduce force vector to reduce risk. Need to do single limb performance to assess, so just single limb squat and jump. And then to assess a squat, we want to look for a lateral shift to one side, showing that there's unequal weight force distribution, which then leads to a strength deficit on one side. You talked about the correlation of concussion to ACL risk, which I think is such an interesting correlation
Mhm.
that I hadn't necessarily put together previously. So thank you for sharing that. And showing that 1.6 times greater risk of ACL injury post-concussion. Concussion impacts single leg performance. You talk about the tests that you perform, doing a plank and a squat, and then doing single limb squat, hop, plank, or plant, and then lunge. And wearable technology, you shared with us the ViMove plus AMI, which is lab quality data wearing sensors that capture movement at about 200 frames per second, interpreted by computer analysis, and then the data goes into an overall database. And with biomechanics, poor biomechanics changes force attenuation and altered force production, which leads to increased risk of injury and decreased performance. Therefore, if we alter and change and improve biomechanics, we have less risk of injury and better performance. And movement tells us the root cause of the weak link in the system. So, for example, if that was a great example of stepping up
Mhm.
and checking dynamic valgus. One patient had arch collapse while the other had hip weakness. So we see dynamic valgus in both patients, but it's a different case presentation completely. And then doing a side plank as an assessment. So looking for tibial drop where the ankles should be neutral, shows weakness of anterior tib and peroneals. Looking at the glute medius weakness, hip roll forward or backward can be QL, quadratus lumborum, and then shoulder rolling can be serratus anterior or rhomboids. And then checking dynamic valgus, speed matters, with pelvic control, looking at magnitude and speed, with power variance, degradation of force over time and power, kinesiophobia, the impact on movement due to fear of movement, and then concussion impact on dynamic valgus. So you talked to us also about limb symmetry index and limb quality index, so LSI and LQI, which is important for return to play information. And then ultimately those takeaways were importance of nutrition, implementation of blood flow restriction, which is a complete game changer, or motor unit activation releases growth hormone, control dynamic valgus, loss of balance leads to loss of pelvic control or is associated with loss of pelvic control, kinesiophobia, lateral shift in a squat and quad deficit, concussion, direct impact on valgus, speed of valgus, and balance, and you're now assessing degradation over time and the impact of fatigue, and then pelvic stability is an important for single leg performance. So many great clinical takeaways. Thank you so much for all of the work that you've done to assess this information, collect the data, and then, of course, contributing to the literature and contributing to the community so that we can have better understanding of biomechanics and their true impact. A couple questions for you. Number one, is this technology available to clinicians to utilize in clinical practice, or is this more so for just for a laboratory setting?
No, it's actually available for clinicians. The way that it's used mostly in clinical settings is for rehab, for assessing risk. We've done it for mass physicals. So we've done upwards of over 3,000 firefighters in one mass testing. So it is very efficient in that regard. And then it's also being used a lot in the industry for making return to sport decisions
Sure.
after an ACL reconstruction. So that in that realm, there's not a lot of consistency. And what this does is it actually gives us a very distinct way of measuring it in an objective fashion that gives orthopedic surgeons more information.
Yeah, I love that objectivity so that it's not
Mhm.
left to subjectivity and we can evaluate very specifically when the
Yeah.
patient's ready to return to play. Excellent. And then can you talk to me a little bit about we do, at the American Posture Institute, we do static and dynamic posture evaluations. Are there anything that is there anything that you're looking for specifically with a static posture evaluation, specifically that would indicate that we need to do pelvic prehab to prevent an ACL injury or rehab post-injury?
Yeah, so we do a postural assessment that the sensors actually calibrate for what that individual's posture is. And part of the reason that we're capturing that is number one is that we want to start to see if there are some correlations with that
Mhm.
as it relates to the individual in the sport. What I will tell you is that we haven't gotten enough data yet because what I will tell you is that a 16-year-old female soccer player moves very differently and looks very differently than a lineman
Sure.
that looks very differently than a running back. And what puts one at risk versus another at risk versus another at risk is very different. And historically, what we've done is we've categorized them all together. And so what we're trying to do is we're trying to tweeze that out and see what common factors do we see that's associated with those. So although we're measuring it, we don't have a lot of enough information yet to really kind of make some guidance from a clinical perspective.
Got it. Well, thank you for sharing with us your goals because we know that you're continuing to innovate
Yep,
and continuing to make a huge difference in the community and to so many athletes out there. We truly appreciate you sharing with us today.
absolutely.
And as we wrap up another great session on the Sports Rehabilitation Virtual Summit, I'd like to acknowledge Dr. Nessler for his excellent work in sports medicine. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to help your athletic patients perform at their highest level. I'm Dr. Krista, your host on the Sports Rehabilitation Virtual Summit. Be sure to get the Sports Rehab Power Pack for on demand access and simple implementation into your practice. Stay tuned, and we'll see you on the next Rehab Masterclass for the Sports Rehabilitation Virtual Summit.